My name is Erik Alexander. I'm the Executive Director of the Brigham Education Institute. Together with Gaviola, Subha, Ramani, we're just thrilled to welcome you to this session, the third in our series of 7 seminars on medical education research. So the three of us have had a lot of fun through the years, really setting the stage here for a very initial simplistic approach to understanding medical education research. It is not meant to give you enormous amount of depth here. That will come with later sessions or with more work that you'll do or one-on-one sessions with any of us. But really just to kind of broadly give this idea of how you can think about medical education research from either a qualitative or quantitative viewpoint or both in terms of a mixed methods option. I will spend 2 minutes kind of saying what I think you already know, which is the interest and ability to publish in the medical education sphere, and we'll give you just a few tips on that. We will then dig into the 2 different approaches here that one can take, and the differences really in data collection, analysis, and interpretation, really providing the building blocks, we hope, for starting to think about your next project. And we welcome you at any time to reach out to any of us in the BEI if we can also give advice along the way beyond this. And we'll do this very practical as well by trying to give some examples. And then at the end, a little audience participation where hopefully each of us or some of us can join and think about how we would approach a novel question together. So this is just one way to think about medical education research, which is to type those 2 words into PubMed and see what pops up. And what I make note of really is the inflection point that happened now about 5 to 10 years ago, where the quantity of published research and published peer-reviewed articles in the field dramatically increased, as have the ability and number of journals to publish this research. So the time is now, in a sense, and the opportunity is now. And there are many different medical education journals. The point here is not to give you a list here to memorize, but rather also to share with you a very important resource. So the AAMC's group on educational affairs put this together now 3 to 4 years ago, this annotated bibliography of journals for education scholarship that a lot of us access regularly when we're thinking about where we could submit or where we could submit next if we didn't hit the journal we at first had wanted. But that is a searchable item on the internet. You can easily Google that, pull that up, and it provides a good resource for you to think about where to publish. If you haven't heard the term impact factor, that's why I put this slide first in here. This is an older slide. It actually shows data just through 2011. But the idea, of course, is the impact factor is the impact that journal has, the awareness, the breadth it has to be often quoted by others. So in general, the stronger the research proposal or document or project you have, often the higher the impact factor journal that you'll be looking at to submit. So always a fun exercise to ask yourself, what's the impact factor of whatever journal you're thinking about. But the tip I'll give you is this as well, which is beyond just thinking of journals that publish medical education research, also think about your specialty journals. If you are a surgeon, often your surgical journals will be taking articles in education. The same would be in GI or endocrine or whatever your interest is. And certainly for real big educational articles, the very big journals like JAMA, New England Journal, they'll take some of those education articles, but they'll expect them to be of the quality as they would any other of their articles. So those are very high bars to get into. And I'll also just kind of finish the introduction with this, which is that a medical education publication can be a lot of different things. We're going to talk today about medical education research, the novel idea that you're discovering and you're sharing and showing something. But in this field, there are many other ways to also get out there with published articles that are equally important, and they can be sharing a curriculum, they can be descriptive efforts, they can be speaking about professionalism or viewpoints on a topic. They don't have to just be in the 2 areas that we're going to discuss, so keep your mind open. Even the last page in academic medicine is something we're using more and more in the BEI, which is a 1-page submission. So there's lots of opportunities to think about. All right, and as you start thinking about medical education research, a few tips. The first is, and this was a tip given to me a long time ago, but I do like to share it, which is the temptation, if you're somewhat new into this process, is to focus more on the learning with the idea that someone didn't know something, you taught them something, and then they learned something. Well, that's really good. That's what we do as medical educators, but that really isn't the novelty we're looking for in published research. That's kind of the assumption of what education does. And so always remember, if you can, as you're thinking about a project, to be focusing on either the behavior of the learners or the educators, or perhaps the process of how you're teaching, or the system of learning in which this occurs within. You can do things like modeling a new curriculum. You can observe different behaviors. You can describe the environment. But the other thing I underlined for you here on the bottom is increasingly try and always anchor yourself within a known framework that you're going to put your research in, or building itself on a theory grounded in educational structure or theory. If you don't really understand where you're going with those two things, a framework or a theory, we can reach out to us at any time and we can dig into those even more. But I think those are really going to be core concepts that we want to launch with, or give you the advice to start with. With that, I am going to actually just do this one last slide here and then turn it over to Dr. Gaviola. I like to always begin with people also who are often day-to-day working in healthcare by acknowledging why medical education research often will feel at first a little bit different to you if you haven't been in this space before. And to me, it's a kind of going back as well to acknowledge that when you're training in healthcare, training as a physician or a nurse or any other activity, you often are very grounded in the physical sciences. That a pre-med curriculum, medical school, nursing school, any school in healthcare really is teaching oftentimes people to find so-called the answers. And certainly in medical school, you have to take your pre-med courses of physics, chemistry, biology, et cetera. But the social sciences are actually very different. Some of you have likely taken courses in the social sciences, like education, like psychology, anthropology, sociology. The idea here is that we're, of course, not inanimate objects, that learning is a complex entity. It can't be quite so narrow. And to make this a little more complicated, I would argue that medicine itself is an application of both. It's an applied science. It's a life science, if you will. But going back to the question, why can medical education research feel different to you? Well, I would argue that for most of us, the day job kind of lives in this world of physical sciences. If we're treating patients, if we're trying to think about a therapy or next step, we're often trying to go to the literature to understand if X is greater than Y, et cetera. But when you move into medical education research, the mindset is much more in this social science domain. So you do have to really shift a little bit, or at least acknowledge that some parts of your work week are going to be a different thought process than others. I'm going to now stop sharing and turn this over now to Dr. Gaviola.
All right. Thank you very much, Erik. Hopefully everybody can hear me okay. So I noticed one of the comments from Subha in the chat was thinking about who your audience is once we get to discussing about medical education research. So with that, let's consider a couple of options here. Let's say we want to study a new drug called vitamin M. And our question ultimately is, how do we know its effects and the treatment of asthma in humans? So what are some of the ways that we can conduct this study? Well, probably a most common in medicine that we see, this is a common question, we see the effect of a drug and its outcome is really looking at some more quantitative things like looking at lung function tests or looking at the number of ER visits the patient may have presenting with acute asthma. So these are pretty common. I think many of us are very familiar with these. So obviously that might go in a journal like the New England Journal of Medicine or Annals of Internal Medicine. So let's take the same question now and think about a different question or a different audience. Let's consider this vitamin M drug and think about its effect in the developing fetus. And how would we do that study? So obviously that's going to be a little bit of a different audience and a different question that we look at. As a radiologist, this will be something that I think as an imager we could easily do in ultrasound when we look at fetal surveys on patients, seeing the effects on the fetal survey sequentially and seeing if we see any morphological abnormalities that end up developing in the fetus. So another kind of question to think about, let's say we take the same drug, we want to look at its barriers to use in 5 different patient populations. How would we do that? So in this case, it's going to be a little bit different than the other 2 questions. This is where we could use focus groups. We could look at 5 different populations in the community and send out different healthcare providers and survey those populations and actually have a focus group conversation that's recorded and transcribed, and thinking about how they would respond to this with that particular question. So that's a different population and a different journal as well. How about this? What if we wanted to look at it as medical educators, how our doctors learn to use it? So now looking at competency. So now we're looking more towards the, again, the social science type of questions, and how would we do this? Well, we could do ways and looking to see progress as residents go through a particular curriculum that are taught to do this, and trying to see how they would improve. So we could use things like simulation. We could actually have doctors be in a particular lab and try to see how they would apply using this drug in simulated patients. So different ways to address it. Finally, and I think a bigger question is thinking about how this drug would be evaluated in how doctors effectively teach patients to take this medication. How would we do that? Well, this is looking at patient outcomes. This is probably a longer term question, and thinking about, well, how are patients really being treated with the disease afterwards? And this could be things like looking at their compliance rates. We could have visiting nurses come see the patients and actually see how the patients are actually taking the drugs based on the teaching that they've had before afterwards. So as we considered this same question, but different audiences and different studies, we were walking through the spectrum here, as Erik had said, where we were starting to think more along the physical sciences and looking at the treatment of asthma. As we walk through the progression on the effects on the fetus, we start to see that there's a spectrum of the way that we pose the question and subsequently analyze the data from that, looking at the barriers to use, how doctors learn, and then ultimately how doctors teach as part of our medical education curriculum. And the way we can kind of think about this on the physical science end is the quantitative approach. This is usually what we see a lot in the medical literature. What is the most logical? It tends to be reductionist in nature, coming to one particular question and one particular data set that's quantitative. But when we look at this, it can leave you really wondering about the bigger picture, because we're very focused on one particular question and ultimately the meaning of the conclusion in the real world. On the other side, the qualitative approach is helpful because, in some ways, this is a little bit more difficult or challenging for those of us who are so used to being so numerically or quantitatively approached. In some cases, this seems a little bit more nebulous and not quite as exact. However, because of that, this is more holistic and integrative in nature, less reductionist to a particular question, but more meaningful in a bigger question. However, it can leave you ever wondering if the answer is reproducible, transferable, or even correct. So it does have some, flip sides to each of these different approaches. So with that, what we want to do over the next few minutes is actually delve deeper into these two different approaches and how do we approach each one of these as we go through. Ultimately, when it comes down to it, nothing is either all or nothing. You can use both. You could use mixed methods. We use a combination of both studies to kind of figure out and answer your question with that. So with that, we can kind of think about the two in tandem and think about how these approaches could be adapted. Whereas when we take a quantitative approach to a question, we're really more concerned about discovering facts about social phenomenon. Some of the assumptions that we have is there's a fixed and measurable reality, because that's what we're ultimately doing is quantifying and measuring things. And that's how we collect data. We measure things. We look at pulmonary function tests. We look at compliance rates by looking at readmissions or presentations to the emergency room. And then we analyze that data by using numerical comparisons and statistical inferences. So a lot of the biostatistics that many of us go through, and ultimately the data is reported through statistical analyses. So in contrast with that, the qualitative approach, as we said, is really more concerned about human behavior from the informant's perspective. So in this case, we're really looking at the informant and understanding what their perspectives are. So looking at focus groups and barriers to different populations, we want to actually look at the population and see how they're approaching it. Ultimately, we're assuming here that there's a dynamic and a negotiated reality. And ultimately, the data is collected by observation and interviews. And this is what makes it qualitative, because we're not measuring numbers, we're not looking at measuring things, but we're actually looking at people's subjective interpretations of their experiences. However, we still need to analyze that data. And what we do is actually analyze by themes and descriptors that are reported to us by the informants. And Subha will be talking in more detail later on to talk about how we do that. And for those of us who are trained in the quantitative approach, which is how most medical schools approach it, this can be often challenging and a little bit difficult to really kind of comprehend unless you were trained in the social sciences as part of your training. And then ultimately, the data is reported in the language of the informant, again, from the perspective of the people that we're studying. So with that, we're going to delve into each of these. So I'm going to ultimately think about, the differences with the two approaches. Is the questions may be more on the quantitative side, again, what, when, and where. And what we're ultimately going to do is test the hypothesis in a very reductionist way. Whereas qualitative approaches really seek to answer how and why, and then generate hypotheses. So looking at populations saying, well, this population has these particular barriers versus a different population has a different type of barriers, whether it's socioeconomics, it's related to health disparities, etc. So with that, I'm going to pass it over to Erik to kind of walk us through the quantitative approaches.
Thank you, Glenn. All right, so with that, hopefully as a 15-minute or so introduction to kind of the basics of how to think about two different ways to do medical education research, we thought we would kind of ground it now in some real-world examples. And so each approach, as we've kind of given you guidance, will differ, whether it's quantitative or qualitative, but let's get quite practical here and ask three simple questions. How do you collect data in each of these? How do you analyze that data in each of these approaches? And then what do the data tell you via each approach? I'm going to go first and walk through the quantitative approach, answering these three questions. Glenn and Subha then will move through the exact same questions using kind of the qualitative lens. And we'll try and give some examples along the way that at least get your mind thinking in terms of the differences. Starting here with the quantitative approach. So how do you collect the data? And as Glenn has mentioned, and we've already gone through, it really is a reductionist approach. You're defining something you can measure accurately, precisely, reliably, or you're trying to answer a yes/no question. You want to get as granular as you can. And so in that sense, obviously quantitative, we're thinking about kind of a numerical approach almost always. And in fact, kind of a linear mindset that 1 is different than 10, but there's a rank order to it. The variable will influence something and has some downstream effect, which is often important. So you're looking for something small, but you're making an assumption that that's going to impact something educationally that's bigger. When you do quantitative approaches to medical education, much like you would do it in any other type of research, often the bigger the numbers, the better the finding. And the same would hold true in terms of a multi-center approach always being better than a single center. Prospective always being better than retrospective. These are all core concepts simply to make your study less filled with bias and more transferable to others. So those would all be favored. So let's give an example of that. And I like this one a lot, and I'll tell you why. You may remember back, for those who are, I guess, as old as I am, that there was a really interesting article that came out now over 15 years ago in the New England Journal. And this was by Maxine Papadakis at the time at UCSF and a group of other educators. This was in the New England Journal. And what they were looking at is how to understand what they were seeing in terms of behavior and adverse behavior in medical school and its relationship to possible disciplinary action by those same then future physicians down the line. Now, I love bringing that up and describing it because behavior and disciplinary action, I think, lends itself a lot more to the qualitative kind of area of the world. Describing behavior as a yes/no is not really possible. Behavior is a much more thematically represented scenario. So how did they really work this into a more quantitative paper? Well, what they did here is a case control study. They looked broadly at a large number of medical school graduates from 3 different medical schools. And they then were able to track forward and gain access to disciplinary action by state boards. And search the public records as well for all of these graduates. And so they then took, if you will, this qualitative approach on behavior and really moved it into a quantitative conversion. They made it a quantitative metric. How did they do that? Well, when they looked back in medical school records to try and understand behavior, they first had 2 blinded people assess each finding, each event that occurred. And then the quantitative conversion is, even though it was a behavioral event, they assigned a severity rating to it, ranging from 1 to 5, that it was not severe, trace, a concern, a problem, or extremely concerning, 1 to 5. And then they essentially dichotomized the ratings, and you're going to see that here on the right. That if you were a 1 through 3, a 1 and a 2, it was really not as concerning. But if you were a concern, problem, or extreme, if you will, rated 3 through 5, that was deemed unprofessional. And then you can begin to see here on this chart on the right that all about medical education, but now in a very quantitative way, you can begin to see the different domains of behavior: irresponsibility, diminished capacity for self-improvement, immaturity, things that were then noted in medical school. And again, this rating that if they were 3 or above, that was considered concerning. And they did this case control, the disciplined physicians versus the control physicians. And they even were able to calculate out an odds ratio, that if you had these problems in medical school, you were more likely then to have an unprofessional event downstream when you were out in your professional life. Very quantitative. Let's go to that second question. How do you analyze data from a quantitative approach? Well, you start by being descriptive. It will feel very logical to you. Show your distributions. Think about how you'd put together any so-called table 1 in a manuscript. How many people were in the study? Sometimes what are their genders? What are their ages? What are their metrics? We use histograms. We use means and medians and ranges. And then we compare, and the compare can usually be an average of the group of a whole. It can be a before or after change. It can be 2 groups within it, but we're going to try and quantitatively compare groups and see if it's statistically significant. We often will think about a categorical endpoint. If so, we're going to use chi-squared as often, or a similar test as our statistical analysis. If it's a continuous variable like age, for example, we'll use more of a test akin to a t-test. Here's an example of that. This is an article that we had published now again about a decade ago that was just a very interesting question to us, asking what is the length in number of days of the attending student and the resident student interactions on an inpatient medical clerkship. We felt like teams were switching all the time, students were switching on blocks all the time, and we weren't getting this meaningful relationship between the educator and the learner. So we went and looked. It was quite quantitative. We simply got all of the details of who was on various inpatient services when and what days they rotated off. And so even though it was listed as being a 2-week shift, our study was to exactly determine how many days were they really together, hoping that that would give some insight then as to how an educational connection was being made or not facilitated. So the first thing we did here, in kind of almost the histogram or simple figure kind of concept, is on the x-axis we put together what was the total number of supervising physicians that a medical student would see when they were in a 4-week block on the medical service. And it became then the blue bars here, the attending physicians, and the orange, the residents. And this was very telling, right? That while some were lucky enough on the far left to have only 1 or 2 attendings or residents during that 4-week block, so they had a lot of longitudinal connections. If you look at the right here, that there were a number of students who were going through 5 or even 6 different attendings or residents in the course of that 4-week block. No real meaningful way sometimes to form a connection. Now, if you notice, I probably went by too quick. If you notice, I'm almost giving here some interpretation to what the quantitative finding was saying. And that's a little bit of a jump, right? But that's what you kind of, I think, hope that the reader is going to do. They're going to make the same assumption that I did. All I'm saying quantitatively is this is the number of people who interacted or rotated off of that block with the student. The inference, which I haven't proven, and in fact, the qualitative approach will likely give a lot more insight into. The inference, though, is that this would not be good, that we made an assumption that more direct one-on-one connections for the entire 4 weeks would be optimal. Another graph is then, well, if they were rotating on and off, what was the sheer length of interaction in number of days that the student would have with the attending? And just what was the variability? So this is almost a histogram, right? Number of days on the x-axis. And we saw that, kind of 5 days was the most common, and then 12 was the next most common. That was certainly related to likely the 2-week block and various roll-on, roll-off days that they were engaged with. The third question now, what do the data tell you in a quantitative approach? And I was alluding to this a little when I kind of was editorializing the last question. Well, they do tell us precise, and I would argue at times very important data on size, quantity, cost, time, things that are very quantitatively measured. And they can really give insight into that quite specifically. They can also tell you numerical understandings of group differences and changes over time. So if you look back and say, we only had 30 people in our residency 20 years ago, but now we have 60, that's very quantitatively accurate and tells one that you're doubling your size and educational footprint. But when we get to kind of then, well, the accuracy of the data, I think the answer is yes, in the sense that it's quantitatively measured, which is often a reproducible endpoint. But accuracy in terms of meaning is where it gets complex. And I alluded to that before. If we are able to show that students did worse on a standardized test, that's very quantitative, we really can't always infer why did the students not learn that material. That doesn't come forth. We can hypothesize an answer, but we don't know. We certainly don't know what were the groups thinking when we're getting towards some quantitative data. Or perhaps how did they approach a problem differently? Those are going to hopefully be now much better answered, much more insight provided when you think about it from a qualitative approach. One last example that kind of gets at this meaning issue. You may remember as well a very important New England Journal Education article, also patient safety article, 15 years ago by Chris Landegren and colleagues here at the Brigham, throughout the Harvard system at Children's Hospital, that was looking at work hours, resident and interns' work hours, and effects on serious medical errors. So the lead issue, of course, is errors, and you see the quantitative approach, that when you look here on the figure to the right, all the different serious medical errors, preventable adverse events, et cetera, if they were in a traditional educational resident structure, they appeared to occur much more often than a so-called intervention schedule, which was less hours worked or more naps in between. Well, that's good. That tells you a lot also about medical errors. But you'll probably remember then just a few years ago, there was almost a follow-up to this that was asking the question, that change 15 years ago really mandated a lot of differences in how we think about training schedules for residents. But they were also bringing with them some difficulties for sure. And one thing we didn't know, we made some assumptions, is that perhaps education could be the same in a new structure, but we simply would make safety better. We didn't know that. And in fact, whether or not the teaching and education could be delivered to the same degree was an assumption. This follow-up study did not answer that completely, but it did ask the question, do we have to be so rigid? Do we have to stick to that exact schedule that was laid out 15 years ago? And in here, they were really trying to do a more flexible work hour policy and asking if it was just as safe for patient care, and essentially showed that it was non-inferior or was equivalent. And what I'm getting at here, before I move on, is that, again, we can publish quantitative data that often relates very clearly to education, but sometimes it can also force changes in the way we do things, and we just want to make sure that we're not over assuming the answer, because here in the follow-up study, we showed that we could do it perhaps 2 different ways that would be equally effective. But that's where the quantitative piece sometimes traps you into knowing only one piece of the answer and not the whole piece of the answer. So with that, I'm going to turn it back over to Dr. Gaviola. He's going to now move forward once again with the qualitative approach.
Perfect. Thank you so much, Erik. So I want to emphasize a point that was brought up in the chat also from Subha. I want to emphasize that although we said it may seem nebulous, qualitative approaches, it actually is not. And that is the entire point of the series that we're presenting to you today. There's many measures of rigor that we'll go through and highlight for you to really understand the depth of the qualitative piece. So with that, let's contrast the qualitative approach compared to the quantitative approach using the same 3 questions. How do we collect the data? How do we analyze the data? And ultimately, what does the data tell you? So from the qualitative piece, many of you probably already do this without thinking about it. Any of you who have evaluations that you review on a routine basis for a course, you may have a pace where you have a Likert scale, but at the bottom, you may have open-ended. What are the strengths of the rotation and what areas can be improved? That data is essentially a qualitative approach that you're using once you read through that data and identify themes. So with that, we're going to give you a framework for how we really approach that. So ultimately, how do we collect the data? Well, the data, again, is from the viewpoint of the study group that's participating. So these could be in the form of observations, field notes, journals, interviews, focus groups, a review of documents, anything where the responses have open-ended questions or comments. Again, qualitative, not something that's measured. And this could be done in one-on-one with individuals, or it can be done in a group setting. And ultimately, for example, a focus group, like we said, with looking at barriers and look at different populations. Ultimately, that data is recorded either through your camera phone or through a tape recorder, etc. And that data is ultimately transcribed. And the analysis part will be looking at that transcription data as Subha will describe to us. What's important too, to have a scientific framework for how we select the participants. So it has to also be very purposeful, so that what we're doing is not just randomly selecting, but we're also gathering representatives and outliers for the populations we wish to study. The sample size needs to be appropriate until we reach a point of data saturation in which no new data or no new themes are emerging from the additional increase in size of your population. There seems to be a myth of objectivity that may be related to this, but as we'll show you, there's really a purposeful and a very detailed way for how we do this. So let's take an example again, similar to how Erik did. Let's take an example from the literature. This was in the Journal of Graduate Medical Education, which has seen also a rise in the type of qualitative studies that they've been publishing. So looking at barriers and facilitators to effective feedback, this is a qualitative analysis, looking at multi-specialty resident focus groups. So let's look and delve into really thinking about the question they had, which is really looking at barriers and facilitators within different groups on the way they give and receive feedback during their training. So their main question was exploring the barriers and facilitators to feedback seeking in residents and looking at 4 different specialties. Again, so anesthesiology, emergency medicine, OB-GYN, and surgery, and looking at 3 distinct institutions. So here we see a nice cross-section of specialties as well as hospital and teaching settings for the question. The main reason this was done is to show that they have geographic diversity and differences in education programs. So that shows you you're casting a broad net. They looked at a goal of having 8 to 10 participants within the groups to achieve that data saturation point. And the way they approached this was using focus groups, using open-ended questions. Again, that's where the qualitative piece comes in. And ultimately, the questions were identified to provide a framework for discussion, but as things emerged, probes were steered in the conversation to try and elicit more specific data. And again, these were transcribed ultimately and then reassessed. So with that, I'm going to pass it over to Subha, who's going to go into what we do with this data.
So the first thing I want to say is if there's a series then there have to be links between each of the sessions. So I would strongly urge you to start with Ed's. How do you initiate a study, an educational study? That's the first thing. And then we also had, formulating study questions and literature review. Study questions are the anchor of any study. And the third thing I will say before going into my slides, we're providing such a teensy-weensy appetizer. So you're going to go home wanting more. You're going to be very, very, very hungry, almost ravenous at the end of this talk. So if there are many people doing, practically speaking, qualitative projects, let us know. I am more than happy to do an entire workshop dedicated to a practical approach to qualitative design and analysis, which I do all the time. So with that, I will get started. I'll share my screen. Before I actually do the analysis, I think I sent you the link for my 12 tips article to start, on qualitative studies. But I will say there are 3 phases to think about: methodology, methods, rigor. Okay, I like this framework very much. Methodology is exactly what Ed Krupat went through, the 10 steps, the first, and then study questions. The second seminar also comes under methodology. But there is a tricky little thing in qualitative study design, which we are not touching at all today, which is the study design is nothing like quantitative study design. And maybe we'll relegate that for the future. And then we come to methods. Methods is the more what I call methodology is the CNS, cerebral hemispheres version, and methods is the spinal cord version. So you just do it. So methods is recruiting, sampling, data collection, data analysis, and reporting. So that's the methods. And then comes the rigor. So Glenn went through data collection. So let's go through data analysis. So data analysis there is no formula to it, and it's not linear either. But essentially what you do is deconstruct narratives, texts, even videos. Actually, that's something that wasn't mentioned before. Videos, photographs, they're also qualitative data, by the way, and very enriching, and they have their own analytic techniques and much more. Knowledgeable people are anthropologists. I wish we could have an anthropologist with us. So you deconstruct. So the first step of deconstruction is don't do anything, just paper, no pen, no highlighter, just read it. Almost like, for me, Harry Potter, but for you, it might be something else, Lord of the Rings, perhaps. Just read it. Get a sense of what are they saying? Who are these people? What is the tone? What are the emotions I'm sensing? Just get a storyline, what's going on. And then you bring the pen to paper and start chunking data, text into categories. Oh, this seems to be a certain concept, a certain idea, a certain topic, and then highlight them. And then give them a name. That's what's called coding, labeling segments of data that belong to the same concept, same category. That's a code, nothing mysterious about it. And then, but if you have a 10-page transcript, you'll get about 200 codes because you can just imagine. And how on earth do you go about reporting this? So you start grouping these codes, these labels, into what codes seem to belong together. Now, belong doesn't mean similar, can also be different, but somehow they belong. So then you go into coding categories. So, and Glenn talked about thematic analysis. So themes are not the only way to do an analysis, but you can pretty much stop at coding categories. And I created a taxonomy, which I'll show you next. So once you've done all this deconstruction, you now start interpreting, but you need smaller chunks of data in order to interpret what is the storyline, what's going on here, what are people saying, why are people saying what they're saying. So you start comparing coding categories, you start seeing which group of participants is saying what, are they similar, are they different. Once you've done an interpretation, all backed by the data, you start putting things together. That's the reconstruction, because that is a prelude to the actual writing the discussion section, because you're now starting to tell a story. Okay, so, and this is what you would look like, or probably worse, with all the papers sticking to your face, but you know, there is a method to this madness, and it's fabulous. So another very simplistic approach to analysis, raw text, all the notes that you get. That's the raw text. Relevant text, highlighted, labels, as I told you, codes, repeating ideas, coding categories. Themes are groups of repeating ideas, but don't quite fit into a neat little bucket. It's higher, it's more abstract. It's almost what comes from the data, granular, and what comes from the investigator's head, they merge into themes. So that's where the investigator brain comes into thematic analysis. And finally, you could, if you want, create a model or theoretical construct or generate a hypothesis. This is, again, much more of the investigator brain. So the participants' words to investigator brain. And you will see in the next, raw data to codes, lots of them. Then group them into coding categories. Then thematic analysis. And then you can actually get into a theoretical construct. So in a way to look at it, you go from the concrete to the abstract. But whenever you go into the app, and you will see qualitative papers diving in and out of the concrete and abstract, but always backed by what participants said, because that's the data. So, oh, this is you or me? All right. So I'm actually going to skip over this constant comparison, but just to tell you that constant comparison is an approach that is recommended for a particular type of qualitative study called grounded theory study. And you go back and forth, comparing your codes, comparing your themes, and then saying, okay, what rises to the top? What seems important? And the themes and codes keep changing when you do this constant comparison. And then it's called, axial coding, which is what is the relationship between this? And we will leave that aside for the moment, and then talk about reporting to what is our job as an educational qualitative researcher. We tell a story, but a very scientific story. You convey the main messages with authenticity, meaning your paragraph, your interpretation is always accompanied by a representative quote. And that's the only way readers and reviewers can say that you've not gone off willy-nilly on your own tangent. You represent the voices of participants. Remember, this is sociology, this is anthropology. So the downtrodden, this is how it was written before, the downtrodden, their voices need to be interpreted. So the number of times somebody said something is not important, but the depth or the significance of what is said even once is important. That's a slight difference. Maintain and demonstrate reflexivity. Reflexivity is where we, the investigators, are constantly thinking, what is my assumption? How am I related to this topic? What is my interest in the topic? What are my biases? What are my assumptions? And am I allowing them to sway the way I pick my participants, sway the way I ask questions, or even interpret, just trash the ideas that don't agree with me? No, that's wrong. Reflexivity is not chopping off the investigator head, but knowing that the head is full of biases, being aware of them and addressing them. And then explain how your findings shed light on the question. So we talk about, in the end, I said methodology, methods, and then rigor. So there are comparable terms from quantitative research, but we don't use the same terms. So internal validity is credibility. So do the data say what you're trying to say or what you're trying to achieve? Reliability is called dependability. So can somebody, let's say at Yale, apply my findings to them? Similar, essentially, have you written what's called rich description, have you described the methods with rigor. And so Yale is an urban, large program, so similar to Brigham probably. And can they say, all right, I can apply these data? But the other thing is transferable, which is the generalizability, which is, can I actually go beyond similar contexts? Can I even reproduce these studies at my own institution? So there is rigor. And Bridget O'Brien from UCSF, prolific researcher, and she and her colleagues wrote an article in Academic Medicine in 2014. Anyone who wants to write qualitative research should read this. This is a must. And I think, okay, and there are two ways to report a results section, depending on the word count. You have to be rather cunning this way. So JGME, Journal of Graduate Medical Education, the word count is very, very, very limited. So what people tend to do in qualitative research is give a summary in the results section. So it's a very short one because methods have to be very, very detailed in qualitative papers. And they put the quotes and the themes as a table. You will see this quite a lot. Whereas there are others. Okay, there we go. This is my paper. This is Academic Medicine. And they have word count limitations, but for qualitative, they stretch. So it goes to about 5,000. And so in this, actually, results are actually written this way. So you see what I said? This is a description of the theme and then what the residents said, like so that I back up, this is representative. So that is sort of, hopefully, made you hungry, ravenous, and you want to eat more. So we'll have a dinner which has a main course at some point.
Excellent. And just thank, first of all, my co-leaders here in Dr. Ramani, Dr. Gaviola. Also wanted to thank Christina for the chat monitoring, and also make sure you were aware of our other leading education scholars in the BEI, Ed Krupat and Martin Puchik, all of whom are wonderful resources for you. But hopefully this has been, as Subha said, just the very beginnings of a taste of how to do medical education research. Really the very, very top understanding of how you can begin to think differently about doing it. And there are many different approaches. There are quantitative studies that often feel more part of kind of your day-to-day biomedical life, answering the who, what, and where, very reductionist, as we talked about, getting into details. There are qualitative approaches that are going to use more focus group observational data. They're going to attempt to generate themes, hypotheses, trying to answer a lot more of the how and the why. And then a mixed methods approach is a combination to some degree of both of these. I think what we'll leave it and end it with is this idea that you can do it. Give it a try, get started, reach out to us, ask how we can help, if we can help. And with that, I'm going to thank all of you for joining us.